I've got all of you experts trapped here with me, so I can ask you the question that all of my colleagues wanted me to ask. When do we transfuse people with sickle cell disease? And should we? And how do we decide who gets transfused?
So my answer, we transfuse the person, not the number, right? I always teach my residents and fellows that. If you have symptoms, the number is low and you have symptoms, that's when you transfuse.
This is an American Society of Hematology Choosing Wisely campaign that you do not transfuse people just because they're having a vaso-occlusive crisis and their hemoglobin has dropped some. It is really, as Jane mentioned, having symptoms.
Right. There are some clear indications, though, both in the
tell me
acute and
those,
chronic
because
setting.
I just thought I heard one. I thought I heard lowering crit and vaso-occlusive symptoms.
No, the opposite. She says
Symptoms of
not
anemia,
to.
Not, yes, symptoms of anemia.
It's actually not
No, I know.
indicated.
Hypoxia.
You're telling me not, let me be clear. You're telling me that just because they have symptoms and a low crit, I don't have to transfuse.
If
or I
they have
shouldn't.
vaso-occlusive crisis pain
Yes.
and a low hematocrit, it's not an indication for transfusion.
That's what I thought I heard.
Yes.
And my colleagues who are not read into this would say, but wait, the crit's low, they're having pain, it's vaso-occlusive with these bad red cells, give them good red cells. What's wrong with that logic?
It's never been proven to shorten the duration or intensity of a vaso-occlusive episode. And all you're doing is exposing patients to some of the complications that we all dread, which is the formation of red blood cell alloantibodies, which can make it harder and harder to get the next transfusion there, and iron overload, which is a major problem in individuals with sickle cell disease.
So let me turn this upside down. You're telling me when not to transfuse.
Right.
When do I transfuse?
So I can start, so that I like to think of it as sort of the acute indications and the chronic indications, so I'll take the easier one. So chronic indications, the most clear cut is in the setting of high risk for stroke. So either you're concerned about a first stroke or a second stroke, and this is born out of the pediatric literature that showed if you screen children with a non-invasive test called a transcranial Doppler, and you saw an indication on this test that the patient was at high risk based on their velocity of blood flow, then those kids should be on long-term regular transfusions.
But I thought I heard at this table that all people with sickle disease are at high risk for stroke, certainly higher than the population at large.
Yes, they are.
But you have tests to identify people who are at higher risk, right?
So
Our
you would really want to see an occlusive issue with the arterial supply to the brain.
No, occlusive.
And
No.
then, well, she said an ultrasound to show high velocity.
So
To
there
me,
are
that means occlusive.
you can go ahead. But there are, the brain is a large organ, and the blood supply can be in big vessels, and then when you look inside the brain, they can be very small capillaries, have very small areas. The transcranial Doppler really looks at blood flow in major large vessels. So 25% or close to 25% historically of sickle cell anemia people would have a full hemiplegia by 45 historically. And when we started screening the Doppler in the neck and we picked up functional evidence of narrowing, over the last few decades, that rate has dropped dramatically by identifying those who have an increased flow with no symptoms and starting them on transfusions. Now, the other blood vessels, the tiny ones in the brain, they can be occluded separately from the big ones. And in adult and pediatric trials, roughly about 50% of adults will have, in early adults, in the 30s, will have evidence of silent infarction. So the brain is not just the big vessels. There's a lot of ongoing damage to the little vessels, and more data is being done in kids and adults to see if transfusions can prevent those little vessels from being
We
occluded.
come back to my confusion. If everybody with sickle disease is at risk, much higher risk than the general population of stroke, and if we can't even identify the tiny vessel disease with ultrasound, as we can with the larger vessels, why shouldn't we, and just give me a reason, not transfuse these folks? I don't know.
Well, we are screening now children and adults with MRIs. The ASH guidelines have recommended, and the pediatric studies have recommended, that we now initiate routine MRI screening at specific points for these populations, so we can start picking up the very high risk, either intervening with transfusions, or at least identifying those who are at higher risk. And while that not be agreed with everybody, there are people who feel that way.
This is why I
not a
love doing
lot
these
of
broadcasts.
data.
It's the cackling, the wonderful laughter over here. The rest of the
very
panel.
little data.
Right. Well, so the issue, right, is that even if you identify something on an MRI, especially in an adult, there's no data about what to do with that information. And so, right, doing a screening MRI that may show something in a 30-year-old, it's unclear that the right thing to do is put them on chronic transfusions because there's no data.
Well,
For
if you were a
every-
non-sickle cell patient and you had a test and you could predict they're going to develop Alzheimer's and they have some vague symptoms, would you do the test?
I don't know.
Would
Well, I'm
would there
just
be
saying.
something for me to do to
Well,
to treat
Alzheimer's,
it?
there is more to therapy. There is a whole bunch of care that is beyond just transfusion.
So I might favor screening for neurocognitive dysfunction.
I agree with
Right,
that.
because then, right, you have something and there is an intervention that can be done to help those people
I agree
and
with
provide
that.
those resources.
If you could get neurocognitive testing done,
yeah.
I would agree with your point.
Right. And then the other reason for not broadly offering transfusions for people who have brain lesions, for example, is that we know that those lesions progress even when you're on transfusions. So for me, it's a little
Less.
bit difficult. They still do.
progress
They
less.
progress less, but they still do, right? It's not like I'm going to prevent 100% of new silent infarct and stroke if I transfuse everybody. So it's, for me, when I have those discussions with families, I have to be honest. I say, I don't know if I'm going to put your child on transfusions because there's silent infarcts here and they're not going to have it again. It may slow down. And then the family gets really conflicted because they know the side effects that transfusions are going to bring. So, and then there's hydroxyurea. There was have some evidence hydroxyurea could slow down
That's true.
too.
You know,
So,
in the era before we were able to screen for HIV, before we had an effective screen for hepatitis C, I personally could understand more of the reluctance to transfuse. The hemochromatosis bothers me, obviously, and it's a balancing act. But I don't know. I'm confused. My colleague.
I think the bigger question, we can get into therapeutic interventions with transfusion, but I think the overriding concept that is important to me is that it's a neurodegenerative disease, and that the kids and adults, however you want to have progressive problems over time. And as they get older, multitasking in certain adaptive tests that they need, that most people have, they may have more difficulty with, which would limit their ability to go through a complex health system. And so at least the physicians and medical community needs to understand that as they age, they may be developing more difficulty in cognitive managing a complex bureaucracy, and that this isn't a sign of behavior or maladjustment, it's a sign of neuro issues, and we need to be aggressive, whether with navigation skills or other techniques, but at least recognize when you deal with these people that they have a neurodegenerative disease.